Hello, my name is Dr. Shanda Blackmon. Welcome to the Baylor College of Medicine Lung Institute podcast series. We're here to communicate with all of our care providers, our learners, and our community, as well as patients, about how to improve lung health, how to educate you and all of the people around you about ways to prevent lung disease, treat lung disease, and maintain lung health. Hello, my name is Dr. Shanda Blackmon, and I'm the Medical Director of the Baylor College of Medicine Lung Institute. And today I'm here with Dr. Gabriel Loor, the lead for our lung transplant program. Welcome, Gabe. We're very excited that you're here.
Thank you. It's great to be here.
Gabe is a cardiothoracic surgeon. He's been here for how many years, Gabe?
8 years.
8 years.
Yeah.
So I was here 20 years ago as a resident, and then I left and I came back. And so it's great to rekindle old friendships and then meet new friends and get to know what Gabe's been doing while I was gone.
Yeah.
So Gabe, tell us a little bit about what you do and how you've been changing Baylor College of Medicine lung transplant here at Baylor St. Luke's.
Sure. So I'm the surgical director of the lung transplant program. And in that role, we've been trying to develop a program that is an important asset to patients in Houston, in Texas, and then really anywhere in the country or in the world who are in need of a life-saving donor organ transplant. Usually, these are patients that have end-stage lung disease from a variety of different illnesses, ranging from COVID-19 to COPD, to acute or chronic pneumonia, cystic fibrosis, pulmonary hypertension, ILD, we have a pretty big team and a big service line that is devoted to them. So there's a lot of moving parts to that, and that's what I've been kind of working on throughout these last couple of years.
Great. So I know a lot of people out there in general don't understand what it means to do lung transplant other than putting someone else's lungs into a new patient. What is it that patients need to know if they think they might have lungs that are failing? What are the criteria for a lung transplant?
Sure. So fundamentally, it has to be a lung disease that has no other cure. There's no medical options for it. And without a lung transplant, the patient has no more than about 2 years left to live. So in those situations, then they meet the basic criteria for lung transplant, and then we just have to make sure that the surgery is going to be safe enough for them to withstand.
And lung transplants require a lot of resources. And as you've been growing the program, you've been doing more and more. How many did you guys do last year?
Last year we did 108. Lung transplants, yeah.
And how many are you projecting that you'll maybe do this year? More or less?
Probably more, about 120 is what it seems like, yeah.
And are you the only one that does it, or are you on call 24/7
and
no. Exhausted?
No, we have a couple of surgeons that are involved in it. Myself, Dr. Fernandez, Dr. Shafi, Dr. Liao, and even thoracic surgeons like yourself that have helped and are helping out with the call pool in many different ways. So it was a big program.
Well, it does require a lot of help, a lot of support. How often do you find people are on some type of lung support when you take them for a lung transplant?
Yeah, so the most basic support being like a ventilator. Most commonly, they're not on a ventilator. They're actually on an ECMO device because we like to have them awake and talking.
Just for the audience, ECMO is extracorporeal membrane oxygenation. It's basically a cannula that goes into the artery, a cannula that goes into the vein for VA ECMO, cardiopulmonary bypass, and then a veno-venous cannula or a dual-stage cannula that goes in for venous ECMO.
Exactly. And the venous one is the more common. The venous one is becoming more popular even and safer now than it ever was before. So it delivers oxygen directly into the bloodstream. Because in many cases in these patients, even with a ventilator, it's not enough to push the lungs and to give oxygen into the lungs. So the only way that they can get is to bypass the lungs completely just by giving the oxygen directly into the blood. So it's becoming very common. And in fact, even in patients who might need the ventilator, we almost just forego it and go straight to ECMO.
And that's because it doesn't put pressure on the lungs. It keeps you from injuring the lungs, and people are much more comfortable maybe having an ECMO cannula in that can maybe go a little bit longer than having a device in their mouth breathing for them, right?
Yes, definitely. It's a very scary situation, but the patient is awake and they're pretty comfortable. They don't have that same air hunger that they otherwise would have. But by the same token, they're really living on the edge because the ECMO is completely supporting their life while they're on it.
And then what about people that are in other hospitals? If their lungs are failing, do you go out and get them and bring them here, or do they call you and they come here? How does that work? I've always wondered if someone's coming from another network or institution that doesn't have the same resources that we do.
Yeah, that's a great question. And we thankfully, and especially in Texas, there's a lot of awareness around ECMO use and how to deploy ECMO resources. So a lot of hospital facilities do their own ECMO. And then we have a lot of different third-party facilities that can provide air transport for these patients. We are in the throes of discussing a mobile ECMO unit where we would actually go out and cannulate. But given how much time we spend here and how intensive it is here, it's actually been helpful to leverage the expertise of the community. But we take patients from far and wide. The most notable one was someone that came to us on ECMO from Hawaii. And so they were put on ECMO there, and they tried many different programs in their region or in the state, and even in the Midwest, anywhere to provide the service that they needed. But for a variety of different reasons, the patient was turned down and was sent to us air flighted on ECMO. We received them, we rehabbed him, did his transplant, and then he's back in Hawaii doing really well.
Wow, surfing, going out there,
yeah,
having a great
probably.
life.
Yeah, he's probably surfing, yeah.
So one of the things that always impresses me most about you is that you're not just an average lung transplant surgeon. You're one of those people that's willing to take a risky patient that maybe some other programs have turned down, and you'll take a chance. And how do you sort of decide who you're going to accept, and what makes you feel like you can get somebody through a lung transplant that maybe other institutions might not be able to?
Yeah, that's a great question. And there's definitely an art to this. We have our recipient selection and contraindications, indications. But we really push ourselves to try to learn from every experience, from every case. We have a lot of investigation into things that we were doing well, things that we were not doing well. I have to say that fundamentally, I think that our program and the resources that our intensive care units offer is very important for this. Mm-hmm. This isn't something that any one individual could do. Our operating rooms are well versed in advanced heart and lung disease for many, many years here since Cooley and DeBakey started this year. And so the complexities is something that the program as a whole tends to be pretty familiar with. Mm-hmm. Then there are some kind of trade secrets or know-how around the technical parts of the procedure that we navigate really well, and that comes from a lot of our background and training. And that also helps us to mitigate risk. So it's the whole package. There's no one element that lets us do it. At the end of the day, though, it is the confidence in knowing that we can offer them something, and I think that is something that we do leverage, and it has helped us in cases that otherwise the patient might not have had access to a life-saving transplant for sure.
Well, that's great. You know, one of the things that really worries me about lung transplant is that there aren't enough of them to go around. People die on the waiting list. People are desperate to get their lungs. Maybe they get sicker while they're waiting, and they can have other organs that go bad while they're in that situation of waiting for a lung. You and your team, y'all are working on maybe a better solution. Can you tell me a little bit about that?
Yes, definitely. Interestingly, only about 20% of the lungs that were offered we actually use. 80% are still discarded. Over the last decade, there's been a concept called ex vivo perfusion that allows us to investigate an organ's quality outside of the body before it's implanted into the patient. And we've seen a lot of evolution in that. We've been involved in many clinical trials around it, but we realize that there's still a lot to learn in that space, and we have many limitations that we're trying to surpass now. There's a lot of resources around technology at the Texas Medical Center and Device Innovation Suite. We've partnered with several engineers here involved in many high-valued areas of cardiopulmonary resuscitation to develop and conceive of a system that allows the organs to be outside of the body for more than 24 to 48 hours. We think that's important because it helps the organ recondition and allows us to get access to more of that 80% that's currently being wasted.
So for the public, this is a lung in a box,
Yes.
essentially.
Yes.
And the lung in a box is like some other companies that make lungs in a box, but the one that you're driving is a lung in a box of solution, where the lung is floating in this
Yes.
liquid so
Yeah.
that it doesn't get damaged or dry out, or sort of seems to be more preserved, more like it is in the body. It's
Yeah.
floating around in a solution inside our chest, bathed in liquid almost
Correct.
all the time.
Yes, absolutely, and because the human body is incredible, obviously, but you appreciate it even more when you try to mimic the human body outside, whether it's in a lab research or you're getting involved with ex vivo perfusion of any organ. You realize that the human body is the ultimate host of any organ. Obviously. So to replicate that, there's a lot of conditions, and one of them is, as you mentioned, you need to have an atraumatic environment. You have to have some surfaces that don't damage the organ, and the ability for the organ to move around also is very important. So that aqueous environment has been important. There's other elements like nutritional delivery, total parenteral nutrition, dialysis needs that in the human body we take for granted, but when you have an organ, you have to be able to clear metabolic waste.
So let me just interrupt you for a second. The total parenteral nutrition is like giving it food,
Yes.
so that the cells don't die.
Absolutely.
And then the aqueous solution is just putting it in that water that sort of bathes and protects it.
Correct.
And then dialysis is like taking the extra fluid out, taking out some of the bad electrolytes and replacing it with healthier electrolytes,
Yeah.
sort of like a kidney would normally do in a human.
Exactly. That's exactly right.
amazing.
Yeah, that's exactly right.
And then can you deliver therapy? Can you give gene therapy? Can you give inhaled therapy,
Yeah.
or all types? So you can take a lung that comes out of the human body that someone is basically brain dead or doesn't need or can't use, and you put it to use and you put it in this solution, and then you rehabilitate it.
Yes.
You put it through some type of rehab, and you make something that would have been thrown away, something that we can keep and put in another human.
Totally. Yeah, totally. And
Wow.
the lung, as you know very well, has the ability to regenerate, and the alveolar cells, they do replicate. There's other organs that are fixed, but
No,
lungs.
I'm going to interrupt again. The alveolar cells are these little tiny sacs. We have
Yeah.
millions of sacs inside the lungs, and that's where the gas exchange takes place.
That's where the magic happens. I mean, that's the cornerstone of life, is that intersection between oxygen, alveolar cells, and blood. And so
I'm going to quote you on that, cornerstone of life.
So we have to allow those cells to be healthy and to replicate when they can, and that's what this environment is striving to do.
So what do you need to be able to solve this solution? Do you think like you just need like 5 more scientists, or a little bit more room in your basic science lab, or some donors to adopt your project? I mean, what do you need to make this happen? I mean, all of us want to see this happen.
Yeah, it's a little bit of all of those, and so that's. It definitely, the process of getting a device from concept to research to commercial availability is a very long process, and there are a lot of resources involved. But thankfully, we really do have an environment here that's very conducive to that, so we look forward to exploring all of that.
So I think it really takes a whole scientific community to sort of huddle around you.
Yeah.
It's not a game that you can play on your own. It's really a team sport.
Definitely.
And a lot of support from a lot of different directions. And the Baylor College of Medicine Lung Institute certainly looking forward to supporting you.
Yeah.
And I know you just recently won a grant to support some of that. So that'll really help a lot.
Absolutely. Yeah.
Good.
Yeah, absolutely.
Good. Well, if you had to look into the future of lung transplant, what do you think it'll be like 5, 10 years from now?
So I do think that ex vivo perfusion is going to be at another level. I think it's going to be fascinating to see how we're going to allocate organs. I believe organs are going to be rehabbed. I think there are going to be better molecular matches. So we're going to have better molecular fingerprinting, which we're already doing. But utilizing it actually in clinical practice, that takes additional leaps of protocols and streamlining processes to do that. So I think it's going to be very individualized therapies in the future. It's going to be fascinating. Organs are going to last longer. The surgery is going to be safer. But also, we are going to be pushing the envelope more and in trying our best to treat cases that maybe we hadn't been, able to treat before, didn't have the courage to treat before. I think we're seeing it daily that we're doing patients that are older that we didn't think we could do before, patients who've had a transplant before, patients who had 2 transplants before. So I think that we're going to expand the options for patients living with end-stage lung disease.
That's great. And it seems to me like you're already working on making it less traumatic, too. Didn't you and Dr. Fernandez do the first Texas robot-assisted lung transplant?
We did. And so that really helped fill us a very important niche. And that is that there are some patients who come with something like COPD or an end-stage lung disease. They're not necessarily on ECMO, but they need access to a life-saving organ. And those are situations where we can actually utilize robotic technology to help do a lot of the dissection. We do it, but we use the robot. Mm-hmm. What it ends up doing is allowing us to work through a very small incision to remove the organ and to then implant the new one. So it's really, really good for patients who are a little bit earlier in the process and are a little bit better candidates for it. We need a good match between the donor and the recipient. But if we have the ideal match, it's great. And this particular patient left the hospital in record speed for us. So I think we'll see that. We'll definitely see that more.
And we have Ravi Ganta, who leads our Atlas AI and machine learning program. He'll no doubt be helping you to look at really unique ways of looking at the data coming out of the ex vivo models to find better ways to fine-tune the lung, ways to supplement the lung and optimize the patient, and all kinds of opportunities for collaboration.
Totally. Yeah, totally.
Well, it's great that you could join us today. We're really excited to have you here as our guest. And we hope that other people can join us as we seek to learn more about lung health at the Baylor College of Medicine Lung Institute.
Oh, thank you so much, Shanda. Thanks for having me.
Yeah, thank you.